I'd like to thank it to my mentors for their excellence and the influence. And also I'd like to thank you to my colleagues for being together for the last 30 years. And I'd like to give a special thanks to Dental XP for the stage to share. Thank you very much. This is my topic today, so one-day implants using objective key factors from traditional to digital workflow. So many of the speakers in the morning gave very, very high topics, high technology. So I'd like to say a little bit fundamental things because this is the implant summit. So I'd like to focus on the implant itself. How we can make one-day implants? Definitely, we have to have some objective key factors to make everything sure. And then, yes, digital is another key factors. So let me show my first one-day implants in 2011. The patient had a root crack here, and with some gingivalizations, and I extracted the tooth and placed implants with the guide, and I did bone graft into the sockets, and also after I did the soft tissue graft with the delivery of final zirconia custom abutments, and then this is final restorations. This is just after, immediate after surgery. What I did in this case is I did the immediate implant placement after extraction, which is very popular and very acceptable nowadays. And I did the bone and soft tissue graft, also very popular nowadays with implant placement. And then I did the immediate delivery of restorations. But temporary restoration is very popular, but not easy to deliver final restoration. In this case, I delivered the final restorations. Not only the customized abutment, and the prognosis, as you see, is very nice. So we call this as true immediate loading, not just immediate loading. So with the final restoration, with the surgical stent, and with the surgical interventions. And we call this one-day implants. And this is another case done in last year. So the patient had many implants already, and the last chance to do one more implant on the mandibular incisors. As you know, that this is a really great site for the immediate loading. So I prepared surgical stent and the customized abutment and the full monolithic zirconia bridges as the final restorations. And I did the surgery with the guided surgical stent and placed two zirconia customized abutment. And on top of that, I just cemented the 4-unit zirconia bridges with surgery. It took less than 20 minutes in total. And as you see, the prognosis is very nice. So this is, we are forwarding to. So everybody will do like this in the near future. But still, we have some kind of some hurdles for the digital workflow. Can you turn off? I think that's better. So this is really minimally invasive surgery, and the one-day final prosthetics will be very common in the near future. And this is R2D4, R2D5, R2D6 implant placement. We made new terms, which is same meaning with Oron 4, Oron 5, Oron 6 treatment based on our software, R2Gate. The patient had huge sinus pneumatizations, and we decided to do 6 implants with these angulations. So it's not easy to place this and this implants at the exact positions, but with many softwares you can use nowadays, you can make a surgical stent, and the implant was placed very precisely, as you see from the intraoral X-rays. It was placed exactly at the same positions And at the same time, we could make a very good initial stability to make the temporary fixed pros on the immediately placed implants. So this is what we want and what our patients want to do. So maybe most of you are very much tempting for this kind of treatments. Yes, this is definitely tempting. Why? Why we have tempting? It's because it looks great. It looks nice. And yes, everybody knows this is a kind of trend for faster loading. And yes, we can minimize the patient visit and we can reduce our chair time. And many of our patients already recognize that we have this kind of technology. And why? But not everybody, not all the dentists can do this. They know the technology, but they're not brave enough to try this kind of immediate loadings. Why? First of all, they have a fear for more failures. Maybe. And not enough digital equipments they have, and not enough knowledges, not enough experiences. And maybe some of them have afraid for the higher cost and more time to work. Yes, it is. It takes time. It can take time. And so we need more experience and knowledge, and you need to prepare more digital equipment. But first of all, you have to have some objective key factors, how you can do this. Yes, let's remind what was our implant system about 30, 40 years before. The old implant system before root form implants were intended to do immediate loading. So including subperiosteal and the transosseal, osteal, and the blade and the disc implants. All these implants were planned to do immediate loading. But this implant has too much technique, test sensitive, and too many failures. And only expert can do this, could do this, because there was no objective key factors for the techniques. So what is objective key factors? The first thing we have to make sure is, so we have to have confidence from the literature review about immediate and the delayed approach, immediate and the delayed loading concepts. So already, I believe all of you already have knowledge about this. So I don't need to mention one by one. So about the immediate placement and the delayed placement, yes, there is no difference from the literature, right? This is quite new articles from 2017. This is 2014. Yes, nowadays there is not many, almost all the speakers say there is no difference between immediate and the delayed implant placement, except some special cases. And how about immediate and the delayed loading? So in 80s, old literature recommended delayed loading because the implant was not so good at that time. But when we moved toward 90s, it's more positive literature came out. And nowadays, in 2000, from late 90s and the 2000, yes, higher success rate, even compared with the delayed loading. The immediate loading has more success rate and better histology. Already many articles proved. Of course, there is some debate still, but yes, more and more positive reports is coming out. Why? And what is the objective factors for one-day implants? Immediate loading, I mean. So we have to have excellent initial stability, not like 20, 30 Newton centimeter insertion torque value. So excellent initial stability means more than 50 Newton centimeters for mechanical interlocking, and the implant should have enough surface contact with existing bone, and more importantly, there should be no drop down of stability before osseointegrations. Then we can do immediate loading and one-day implants. And also, a very careful adjustment of occlusal scheme is very important. From these 4 important factors, the 3 is from geometry of implant, the design of implant systems. And let's review the implant systems we had before. The Biohorizon, maybe many of you already still remember, the Biohorizon developed the 4 different implant systems with the different surface treatments, with different thread design to get the best conditions for the stability. Sometimes it worked, sometimes it doesn't work. And this is very interesting, right? The Sargon and the dually integrated system tried to get more stability from the cancerous bone by splitting the implant fixtures. It couldn't work, right? There's fractures and the infections through the connection. And then Nobel launched. It's quite long time ago, but Mark IV, they insisted Mark IV has a very nice initial stability at the loose bone. It was only 15 to 20 Newton centimeters at the loose bone. Yes. And then again, let's go this part. So everybody knows this graph, right? Very famous. So the red line stands for the primary stability by mechanical interlocking, and the blue means the secondary stability by osseointegrations. So because of this transition period, we have a decrease on the stability in this period, 3rd and 4th week. How we can make it stable? How we can keep the stability we got from the beginning? So this is a headache for the immediate loading and for the one-day implants. I'm not talking with the full mouth case. I'm not talking with the mandibular cases, which has a very good bone quality. I'm talking general for the implant dentistry. It was really a headache to us, to me. So really, I was tempting.
Hi, Billy Mays here from Mighty Putty. The easy way to fix, fill, and seal virtually anything fast and make it last. Mighty Putty is not a glue, but a super-powered epoxy that you can mold to any shape and
So with our steps and my colleagues start to think about the important point of the implant design. What is the important point? Yes, you have to review your implant systems. What kind of advantage my implant system has? Every system has its own advantage, of course. Yes, there are 5 points. The core, the titanium body, should be strong enough for loading. And for the surgery, actually thread design is more important to get very strong initial stability and more surface areas. And then this part is extremely important, as Dr. Shukrin introduced. We have to avoid to give more stress on the cortical bone. So many articles shows we are going to have about 60-70% of initial stability from this cortical bone, but it's not good. It's not good. Because of that, we have a bone loss, socializations after loading. And then connection is also very important for the minimal biological width and no screw loosening afterward. And the surface treatment is also very important. Yes, this is all we have to consider when we decide our implant systems. So I cannot talk all of this because of time limitations, but this is very important. This design is extremely important, knife thread. And this knife thread gave us many benefits, especially for the excellent initial stability and much higher bone implant context. Compared with the conventional thread design, it can give us more than 30%. In some cases, more than 50% of surface areas, which is very nice. And because of this thread, we could make a very good initial stability at the loose bone, D4, and maxillary posterior area, more than 35 Newton centimeters, just by changing the concept on the thread design. It cannot comparable with the Mark IV. This is a kind of a conventional thread design. And this is another very important point for the implant designs. The Enrich implant has 10 different diameters, but actually I can say Enrich has only 3 different diameters. Because from here to here, from 4 to 5.5, the core is same. The difference is the depth of thread. So when we overlap the fixtures, you can see the meaning of the different design. So from here, the core is same. So you can extend your arm into the bone to get more bone and to get more initial stability. But if we place the bigger diameter than the normal diameter of the implants, we need to consider the angiogenesis and the blood splice between the thread. So that's why we made the bigger space on the bigger diameter of implants. So this is another important point. So mainly these diameters from 6 to 8 was designed for the immediate implant placement into the molar extraction sockets. Because of this design, so we could make a very nice initial stability, almost same with mandibular implants. Before Enrich, I just made the initial osteotomy socket according to the manufacturer's recommendations. Because I made the same size of osteotomy sockets, I had to place same size of implants. So as a result, the initial stability was much looser on the D4, the loose bone, and much stronger at the mandibular bone. Definitely, this is true. So as a surgeon, we couldn't find a chance to correct this one. There was some surgical techniques to condense the loose bone, but it was not so great. So the only way we can improve our success rate was wait long at the loose bone. It's the lessons from Dr. Brunmark almost 50 years ago. We are living in 2020 now. How we can improve the stability by choosing different depths of thread. The core is same, can be same, because you made the same small osteotomy sockets and you can recognize the different bone quality during drillings. Then you can choose different thread depths to make almost same initial stability, even at the loose bone. So our purpose was to make the same initial stability at the hard and low quality bone. That means we have almost the same bone implant context, even at loose bone, and no need to wait longer at the maxillary arch. So this is the case in 2010, and in the posterior, second molar area has much less bone quality than the second premolar area. So there was enough width of bone and the keratinoid tissues. So I made a punch with 3 millimeter, and I made a drilling up to 3.8. And definitely during the drilling procedure, I recognized that the quality of the bone was much better in this area, much loose on the second molar area. What I can do, just as I told you, we can choose different thread depths with the same core diameters. So this is 5.5 millimeter with the aggressive thread. It doesn't press the bone. It just cut the loose bone and make more contacts. So I placed the 5.5 here, 4.0 on the second molar area, same length. So I could do one-stage approach. Even the bone quality on the second molar was type 5, almost type 5, type 6, if there is. So you can compare before and after. So whenever you find the loose bone, you need to think about deep-threaded implants to get more stability. Then at that time, in 2010, our purpose, our goal is to make same prosthetic protocols, same loading protocols in the maxillary loose bone, like mandibular protocols. So we took impressions after 3 months and finished the final restorations afterward. But this was just the start. And then the knife thread made a totally different ISQ patterns. It's normally from more than 500 articles, so we made the conclusions with this graph. At the hard bone, the decrease of the ISQ stability made a little bit less decrease, and the loose bone showed more decrease on the stability after implant placement. But anyway, all kind of implant, the recipient bone showed decrease. This was patterns proved from many articles. But anyway, just showed plateau or only increasing pattern, no decrease. So it could make a very good ISQ patterns, not only the strong initial stability. This is case from my colleague, Dr. Han, and he placed, he extracted 2 incisors, and he gonna place 8 implants on the maxillary arch, and he made the sinus bone graft on both sides about 4 months before. As you know, the 4 months is not long enough to make a very high quality of bone regenerations. Anyway, he placed 8 implants like this. Definitely, these 2 implants were placed into loose bone. I can say it's grade 5, type 5. And then this is after surgery, and then this is, and he recalled, Dr. Han recalled the patients every week until 9th week to check the ISQ. Then this is number of maxillary implants, and it showed, all the implants showed the plateaus, no decrease. It should go down like this, then goes up. This is normal, especially at the loose bone, but these implants showed all stability. And Dr. Han made the final restoration, not the temporary, final restoration in 9th week. 9 weeks, 2 months at the loose bone. And then on the mandible, definitely we can try much earlier. So this is, he did immediate placement after extraction of all mandibular teeth and 7 implants. This is ISQ patterns afterwards. So 2 weeks and 4 weeks, but unlike the maxillary implants, it showed only increasing patterns from the beginning to the end, 4th week. It's amazing, isn't it? And he made the temporary, full functioning temporary crowns in 4 weeks. This is very normal nowadays, but it was quite a long time before. So it's very much confidence. So I went to UCLA, and I studied in UCLA in 2000. So I went to UCLA to ask to my professor about clinical studies, about how to, yes, we have many data already with this knife thread, but there was no scientific data, only retrospective data only. So this was prospective studies, and so we're going to place these 2 different thread design into the same patients and compare the ISQ patterns. And the doctors in the peri department placed the 2 implants side by side only on the mandibular posterior, then checked the ISQ patterns for every week for 8 weeks. The result was the same with ours. The conventional 60 degrees conventional thread design with the 60-degree angulations showed decrease on ISQ stability after placement until 4th week and made the plateaus. But this shows only increasing patterns. Not even one implant showed the decreasing patterns. It was really nice. The first clinical studies in the United States on the patients. And then this is new report from Professor Macaulay of St. Joseph University of Lebanon. We tried to set up the fully convinced early loading protocols in 4 weeks, not only on the mandible, not only at the hard bone, everywhere in the mouth. If you can make sure, if you can make the loading protocols in 4 weeks, will be great, right? So he placed implants with our protocols, and the insertion torque value were measured during placement. And yes, he checked the insertion torque with the torquing machines, electronic torquing wrench. Then I was very interested with the result. On the type 1 bone, this is type 1, type 2, type 3, type 4. On the type 1 bone, the average insertion torque was more than 100. In type 4, average insertion torque was a little bit less than 60 Newton centimeter at type 4. And the others in the middle. So insertion torque value in all is about 80 Newton centimeter. Maybe some of you are surprised. If we can make this kind of insertion torque value on the implants, you may worry about the bone necrosis around the implants. But as Dr. Shukrin explained, how we can make sure the bone regeneration and the blood supply around the implants, this is very normal. So this is a position of insertion torque. So some implants here, it had 190 Newton centimeter. Can you believe this? And he said all the implants were successful and was able to have a crown after 4 weeks. And he checked ISQ patterns with a smart pack like this, as just normally. And this is the ISQ patterns. It's exactly the same we had for the last 7 years. In conclusion, he said all the implants were functionally loaded at 4 weeks and presented a 100% success rate. Even we did 100, 180, 140 Newton centimeter torque force on any rich implants. No implants can do this. It's because design. It's because of knife thread. So you can make sure that very high initial stability, which is very helpful for the immediate loading or earlier loading. Then, yes, you can do one-day implants. So during the process, this is very important. Yes, we have many different kinds of ISQ machines. You can use it, any kind. But if you can check the ISQ numbers on your implant on every day, then you will increase the ability of earlier loadings. This is I try to give you questions. So the patient had problems on the first molar of mandibular teeth. And just normally, I extracted the teeth and carefully placed the one implants into the septal area, and I got very good initial stability, and the gap socket was not big. So I put the bone graft and made the one-stage approach. Then we call this immediate placement and one-stage surgery with bone graft. And I'd like to ask you, how long we have to wait in this case? More than 3 months? 4 months? 6 months? This is the X-ray with the follow-ups. 6 months and 3 months post-op. Yes, many doctors said 3 months. So from this X-ray, can you sure to start loading? There was a radiolucency still on the medial and the distal side, distal aspect. So I was afraid. So I waited a little bit longer. So I did temporization in 5 months and finished 8 months. And 1.5 year follow-up, nothing happened. So how you decide the loading time, the exact loading time? Every implant is different, even at the same mouth. Yes, many doctors do make decision about loading time by the time after surgery, by the radiograph, by the experience, or by the recommendation from friends or mentors. But not easy to decide. I'm not comfortable with this X-ray. What is the another parameters? So it took 118 days to have loading. But when I started to use ISQ machines, I could start loading at 80 days. Even I placed immediately after extraction of canine in the maxillary arch. It was good. So I have definitive numbers. This is a simple comparison in my practice. So before Enrich, I used Easy Plus implants, and even I used and I Enrich, and even I felt very good initial stability during surgery. The loading time was almost the same because I didn't use ISQ numbers. So when I start to use ISQ numbers, the loading time, average loading time, became 2/3. So reduced a lot, and the patient's visit reduced as well. And this is very conventional, to us, very conventional, very reliable loading techniques, loading time, loading protocols with Enrich implants. On the day of the implant, you can check ISQ. You have to check the ISQ with the insertion torque value. 1 week later, when patient come back for stitch out, you can check again. It takes only 1 minute, less than 1 minute. And in 4 weeks, as you saw from the studies from Dr. McCauley, Professor McCauley in Lebanon, you can start loading at this time. But I can give you 2 weeks more. So 1 month later, you have one more chance to check ISQ. Then, if it is more than 70, then you can take impressions. Then in 1 or 2 weeks later, you can start loading. This is very, very easy and reliable. Many of you still wait 3 months, still wait 6 months, 5 months, right? According to the stability. You can adjust, and you can check the stability of the implants after placement. This is very simple case. So when I placed the implants, single molar implants, ISQ was 78, no bone defects. 1 week later, same. 4 weeks later, 82 start to increase. Then it's time to take impressions. Done. I took impression with the intraoral scanner. Then 3 months later, I finished. Okay, so follow-up, nothing happens because the numbers tell you everything. So it took 42 days to get crowns. I'm not talking about heroic cases. This is just a routine procedure of my implants. If you have more than 2 implants, SQ was like this, then 3 weeks later, I checked, but it started to increase already. I didn't expect this faster increase, but anyway, numbers didn't lie. So start to increase. When you saw the increase of ISQ numbers, that's the time, that's the point you can take impressions. Then 1 week later, in 4 weeks, I could deliver the custom abutment and temporary crown. At that time, it was increased a little bit more. So in this case, 34 days to have chewing ability. In the maxillary posterior, single molar case, the patient had the bilateral missing. So patient want to have teeth at least this one side. So I chose this side because here we have pneumatizations. I placed 1 implant and I checked ISQ, was 83 in the maxillary posterior. It was exceptionally high. So no bone defects. Even I opened the flap, small flap, was 83, was good. So no need to wait. So I took impressions, and only 1 week later, it's like almost immediate loading, right? So 1 week later, I made a crown on the customized abutments. Definitely, patients will start to chew on this side because no teeth in this side. So 3 weeks follow, 3 months, final restorations, nothing happens. So this is really reliable protocols with numbers, with a very strong initial stability. Then we made the chart with all the data. Dr. Han was the leader, and yes, we have a similar chart from the company who made ISQ machines. And ISQ numbers, sometimes we have fake numbers. So it's much better to combine insertion torque value together. So in the single case, just the case I showed you before, if you have more than 75 ISQ, if you have more than 45 insertion torque value, you can do immediate loading. But I don't want to push you to try immediate loading from today, from tomorrow. So, but just to try this area, 6, 4, 2. You can try 2 weeks later, 4 weeks later, 6 weeks. 6 weeks will be more than enough. And multiple missing cases, more than 2 implants, okay, you can make -5 because you're going to splint it together. So, but yes, try this area, very safe. And then if you have more cases, more and more experience, you can move to this way. And this is just remind you double offset. The design of coronal parts of the implants can make you very nice soft tissues without any surgical interventions, without any surgical or prosthetic procedures, just by itself. Implant design, without big stress, you can make a very good initial stability and very good soft tissue contours. Yes, I cannot say this is attached gingiva. This is just a keratinized tissue, not attached to the periosteum. But this is very stable. I'm a periodontist, basically, but I don't do soft tissue management that much nowadays because it was made by itself. Okay, so far I shared my ideas on the importance of implant design. Yes, the thread design is very important to make very high stability without any decrease afterwards, and how to achieve excellent insertion torque value even at loose bone. So you can use just a different thread depths. No need to use deep threaded implants into the hard bone. It's ridiculous, right? It's stupid. And then how we can use the ISQ values on the loading protocols. Okay, let's try to add more digital workflow. Already in the morning, we had excellent lectures for the future about digital workflow. But my suggestion will be much simpler. Almost same, principle is almost same. So we tried to get digital workflow from 2010, and in 2011, actually, we launched, we made this term, Eureka R2 project for the next 10 years. So the main subject we achieved, the first subject we achieved was R2 gate, the software, which means the entrance gate, any entrance into the R2. R2 means the second revolution in implant dentistry. And then it was intended to do diagnosis and treatment planning. And not only this, so we developed the technique to extract STL file from the software. Yes, nowadays, almost all kinds of software can supply can produce the STL file from the software. But in 2010, 2011, it was not popular. The AltoGate was one of the earlier software to produce STLizations. Basically, AltoGate is the same with other softwares. We combine CBCT, DICOM file, and the STL file, so to make the hybrid 3D digital images. From these images, as you already know, you can see the future crown, and you can see the soft tissue lines. You can see the cross-cut of view of the bone. So you can make a 3D planning according to the future crown. That you can decide the length, angulations, and the diameter of the implants, and as you can do full mouse cases like this, one by one. And then this was not easy to think at that time. Even at that time in 2011, 2010, Nobel used the DICOM file only to make the surgical stent. Yes, definitely it cannot be accurate because DICOM file has more than 200 micron discrepancy. And then the STLizations, we made this term to extract the STL file from the hybrid from the software. So we could make a surgical stent and a temporary crown. Sometimes we can make the final zirconia customized abutment. But single case is fine, but with accumulation of errors, it's not easy to make a free-size prosthetics when we have more than two. And in this procedure, we had some difficulty to evaluate the bone quality. This is guided surgery. When you have a pre-hand surgery, yes, you can assume the quality of bone easily. But with guided surgery, it's not easy to define what kind of quality this hole has. So we developed digital eye functions on the AltoGate. Still, this is only one software in the world. So from the CBCT, all images are black and white. It's not easy to define which one is good. Because of different resolutions of each machines, we cannot say this is really good, this is really bad. We can imagine how hard, how loose, but we cannot calculate. We cannot say this is number 5, number 2, number 1. So but all the black and white has a digital numbers because this is digital. Right? So we made the algorithm to convert all the black and white into colors. So it helps us to understand more precisely about the quality of bone. In this area, it looks like bone, right? Under the sinus, but from the digital eye, it's like almost same with the palatal mucosa. So we cannot trust this bone. See? So you can see on the treatment planning, especially when you plan immediate loading or earlier loading. So you have to understand the geometry of the density. So you can, and according to the bone density, so we can use the data for the drilling sequence. At the hard bone, definitely we need to a little bit over the drilling. But on the D3, D4, on normal quality of bone, we can do exactly as planned. At the D5 bone, very loose bone, we have to do under drillings and need to use deep threaded implants to get more bone quality, bone context. Right? So this kind of advisement will be supplied by our designers. Then everybody can do surgery with the guided surgical stent. When you fixate the surgical stent at the right position, the next is very easy. Just a 10-year-old boy can do this. Then prosthetic procedure takes longer. So this is just after surgery. The patient can start to chew from the dinner. But it looks very easy. But if you try by yourself, not easy. Why? Because not so many people talk about errors. What is the error factors on the computer-assisted surgeries? From the literature, so tooth-supported guided surgery has about this much errors, angulation errors, and the tissue-supported type has almost same amount of angulation errors, about 3 degrees. Not very big. And all the errors comes from this part. Guide design, we have errors from surgical tools, and operation site sometimes provide errors, and the drilling technique also can make errors. So let's focus on the guide design and the surgical tool only. This is an article published by the doctors in Seoul University Dental School, and they compared different surgical guide: Nobel, Austin, Nevisis, NeoGuide, AltoGate. We didn't support this article at all. I didn't know they are making articles on the surgical stent. Then, as a result, AltoGate showed more accurate than any other guided seizure, because of structures, because of this design. Why? Normally, when we make a surgical stent, we print out, 3D printed this surgical stent, and we put metal links into the printed stent to guide the drill, right? And then we use a spoon drill guide to change the diameter of the drills. And then drill itself has some gaps with the drill guide. So this is accumulation of errors. 3D printing, even it is very accurate, it has some errors, some constrictions. And metal, yes, it can be precise, but sometimes can be twisted. And then with the spoon and the drill guide have some gaps, some wobblings. Definitely drill and this spoon has some wobbling as well. So it's accumulation of errors. So compared with this guide without metal, this has more steps to produce, to manufacture. So that's why our guided system has no metal link inside. We removed the procedure to eliminate these errors. So just a printout. Yes, we have some shrinkage. There is. Then the gaps between the drill and the guide. Yes, there is. Yes, we cannot escape from here, from these errors. It's fine. That's why the article showed this result. The accuracy-wise, only the accuracy-wise, you can believe this is the best one ever. Okay, let's talk about the work process of AltoGate. So we make a CBCT DICOM file and STL data from scanning, intraoral or model scanner, and import the data to AltoGate, and the AltoGate automatically merge these two data into one to make a hybrid data, and then you can analyze the patients and you can make a treatment planning, and then when it's finished, you can extrude the STL file from the software to make a surgical stent or custom abutments or PMMA temporary, whatever you want. This is a simple work process. Everybody understand, right? But some of you are very diligent or enough time to make a diagnosis and treatment planning by yourself, but it takes time. For the full mouth case, normally for the virtual wax-up takes more than 5 hours. Even the expert takes 5 hours, but I'm not good for this work. So usually our lab technicians, lab designers helped us. Then I found some problems on communications. He is not surgeon. I'm a lab technician. So we need to communicate more closely, but not easy to make a complete communications. So to solve these problems, communication errors, we made AltGate Lite version, which is available on the iPad. You can have data from your lab technicians through the AltGate Lite version. So, and then with your 2 fingers, you can decide the angulation of your fixture and the depth location, whatever you want. It takes only 2 or 3 minutes. 1 minute for single crown, single implants. So then you can export with your confirmations. Your lab technician will start to produce whatever you want. So AltGate Lite version is really nice. The only one in the world, again. You don't need to sit in front of your computer. So you can go home and on the toilet you can change the angulations. Or on your vacations you can change. So easy, very easy. Communication is very, very important. So all kind of information appears on the iPad. You can download this version. Okay, let's finish with this one more important things. So root membrane techniques, root shield, socket shield, partial extraction socket, partial extraction technique, almost same, different, similar philosophy. So we worked with Michas in Greece and Professor Schoenpars to develop the surgical kits for root membrane. Actually, yes, it's not sometimes easy, but sometimes the drill is not easy. It's not adequate for the root membrane. So we developed surgical drills to complete, to make a perfect result. So this kind of geometric relationship is very important. We have to leave adequate amount of root, and we have to place implants not touching the root membrane. So it should be very precise during surgery. The 2 surgeries, how to cut the root membrane and how to place implants at adequate positions. So we can use AltGate even in this case to make a perfect result. The patient was 69 years old, female, and she needed 4 implants. So I made the planning for the immediate implant placement and the immediate loading with the AltGate. So from the CBCT, I made the planning. Okay, we can do root membrane techniques in this case. Canine has some problems, but yes, we can use this fragment to save. And then, so we evaluated the quality of bone and the angulation of implants and the position of the implants, and it was different side. And from here, so you can see the drilling sequence. Because of the bone densities, our designer recommended the first and second drill, 2 millimeter, 2.5 millimeter, only half of 2.5. No more drillings. Here, first and second 2.5 to place 3.5 by 11.5. This is half length of drillings. So this is from these data, the digital eye functions. So after removal of the bridge, I cut the bone, the root, the shaped, and then when I have adequate shape of the root membrane, then I could start to use surgical stent. Easy. Drilling is very easy. No need to worry about because everything is written on the paper. So I just followed the instructions, then had a very good initial stability, definitely. Then it's time to connect customized abutment. This is the final, not the temporary. Then this is, and after placement of final customized abutment, this is a temporary, PMMA temporary bridges. Not very aesthetic, but anyway. So I made a little bit concavity on this area because of gingivalizations. And yes, just biology. As Dr. Salamer introduced us the transition zones, we can manage the gingival lines and the bone regenerations according to the biology. So from here to here, so only one surgery. And take impressions like conventional prosthetics, finished. So this is my take-home message. Your implant practice can be changed by choosing different design of implants. Check the ISQ and the insertion torque value. This is very much valuable. And be friendly. Try to be friendly with the digital workflow, regardless any kind of softwares. This is definitely the future. Yes, creativity is just connecting things, as Steve Jobs mentioned. So one day implant is not a new one. So I can say, this is a new one. So this is just accumulation of your experience on the implants. Small change, really small change can make a big difference in your practice. Again, I'd like to thank you to my mentors and colleagues and XPs. Very honored to be here again. Thank you very much.
Thank